Welcome, everybody. My name is Jill Comerford, and I have the real privilege and honor of co-hosting today's briefing from DPH with my Secret Service Representative Hannah Kane. And really, the main event are Commissioner Goldstein, Dr. Wong, and the beautiful public health leaders who are going to talk to you about the impact of the legislature's action, both on policy and on budget. But what I want to say is, from my vantage point here in partnership with Rep. Kane, what I see is a long arc to get us here to this moment. And it's taken so many people, and the grit and the tenacity of local and regional public health officials, of advocates like MPHA, and of DPH in our leadership. And I couldn't be more grateful. And I don't want to steal anybody's thunder, because I think what we're going to hear about today is a stellar news story that started with the commission led by our Representative Kane and get us to today. And so why we're having this is that, nationally, I don't have to tell anybody, there is a retreat nationally from public health, but in Massachusetts, thanks to the stellar work of the commissioner, the director, and their teams, we're leaning in with the leadership of local and regional public health. And it's going to take all of us to sustain that kind of focus and commitment. So thank you so much. Over to Master.
So I would just add to that in 2016, when we began the work of the special commission, I see lots of faces in the room for part of that. Some in different positions at the time. But we knew that we had an inefficient and ineffective public health system here in the Commonwealth, that we were the only state that had 351 cities and towns of 351 boards of health who also oversaw local public health. And while the unanimous report that we put out made a lot of improvements, and you can hear about that today, one thing that didn't change is local control over local public health. And that's an important thing for people to understand. Local municipalities still make all the decisions relative to what they want to invest in and prioritize for their communities. What has changed is the fact that we found a more efficient and effective way to do that. That's by partnering and allowing cities and towns to create shared services with other cities and towns so that they can maximize their dollars. And that's really been a sea change. The other big thing that changed is that the state is now investing in local public health, which we were not doing before. There was no line item, there was no support line there for that. And while DPH at the time had a local and regional public health office, the funding that we as the legislature needed to put into our cities and towns was not there. And that's important. And as we are seeing changes on the national level, we are at a point where we need to double down on the fact that we now see local and regional public health as a partnership between cities and towns and the state. And we need to continue that investment. And I'm really pleased to see this briefing today. And thank you all for being here to hear about it.
Wonderful. And I forgot to shout out particularly to Northampton Health Commissioner, the Deputy Commissioner, Michelle Ferry. Northampton is just one of the places you'll hear from, but I'm particularly happy today. So thank you, Commissioner Director.
Break the chat and go behind the podium. All right.
How come you only have 2 pages?
I have the easy joke. Good afternoon, everyone. As you likely know, I'm Dr. Robbie Goldstein. I'm Commissioner of the Massachusetts Department of Public Health. And I want to start today by offering a sincere thank you to two true champions of local public health, Senator Comerford and Representative Kane. You have been unshakable in your partnership and in your advocacy, from those first crucial investments to the successful passage of SAFE 1.0 and then SAFE 2.0. You've been indispensable, so thank you very much for your support. We are here today to discuss a fundamental and truly essential public service, which is local public health. It is the bedrock of wellness in every city, town, and neighborhood in our state. And the Department of Public Health cannot do this critical work alone. The strength of our statewide system relies on the capacity, capabilities, and the readiness of all of our local and regional partners. For decades, Massachusetts has operated under the most decentralized public health structure in the nation, with 351 municipalities and 351 separate approaches. And while the benefits of preserving autonomy at the grassroots level are significant, the downside is the variability in public health infrastructure from municipality to municipality. It creates a system of haves and have-nots. The variability leaves us vulnerable, as the quality of your public health system depends on your zip code and not your need. The COVID pandemic laid bare the profound risk of this fragmentation. It also demonstrated the power of collaboration, coordination, and cooperation in protecting communities, saving lives, and providing hope and support in a crisis. During the past few years, the Department of Public Health, in collaboration with many of you, has made a substantial commitment to transforming the system. We're guided by the 2019 Blueprint for Public Health Excellence. We've had significant one-time investment from the legislature, so we've been able to start to see a dramatic change. For example, in 2019, only a third of our municipalities shared some aspect of local public health service delivery. Today, thanks to our partnerships, more than 90% of municipal health departments participate in a shared service arrangement, which is it's a powerful testament to the hunger for collaboration across our state. Importantly, in late 2024, we added the most powerful tool in our fight for better local public health services and increased collaboration, and that's SAFE 2.0. This law, which Governor Healy signed last November, is moving us from a fragmented 20th century model to a vibrant and cohesive 21st century public health system. Thanks to so many in this room, every community in the Commonwealth, no matter its zip code, can have access to a well-resourced local public health system. SAFE 2.0 strengthens infrastructure, advances data equity, and improves preparedness. It addresses the root causes of health disparities, and it aims to reduce chronic illness, improve behavioral health, and promote healthier lifestyles. It's the pathway, it's the roadmap that enables us to move from reactive to proactive and from isolated to integrated. But this is not merely about preparing for the next pandemic. This law gives local health departments the tools they need to address crises that are now at our doorstep. Climate change, rising maternal morbidity and mortality, the substance use disorder epidemic, and deep-seated and persistent health disparities. SAFE 2.0 is a monumental victory, and one that gives public health the respect and the resources it deserves. Our work now shifts to seeing that every community realizes the full benefits of this game-changing law. The promise of SAFE 2.0 will only be achieved if it is funded and sustained. Without consistent investment, the mandates of SAFE 2.0 will remain words on paper and not protections in people's lives. And that's why your continued partnership is essential. Together, we can help families and communities from Boston to the Berkshires have the same strong shield of public health. With that, I'm going to turn it over to Sam Wong, Director of the Office of Local and Regional Health, who's going to discuss in more detail the investments in local public health and the remarkable journey that we're on together. Thank you, everyone.
Commissioner Director, there are about 60 folks online. So maybe we can just use our outside voices.
Perfect.
Outside voices. Okay.
So that they can hear you, Director.
Thank you, Commissioner. Honorable members of the Legislature, good afternoon. My name is Sam Wong, and I serve as the Director of the Office of Local and Regional Health at the Department of Public Health. Our office supports all local public health departments and boards of health across the Commonwealth. And we are leading the implementation of the SAFE 2.0 law passed by the Legislature last November. I am grateful for the opportunity to provide you with an overview of the Commonwealth's local public health system. It worked. This is the agenda for my presentation today. We will go over some key background information for our local public health system, the journey to transform that system, the Safe 2.0 law, how we are currently funding the system, examples of progress, and we will have plenty of time for Q&As at the end. Massachusetts has a very proud history in local public health. In fact, the very first local public health department of our country was established in Boston by Paul Revere in 1799, when he led the creation of the Boston Board of Health. Today, each of our 351 cities and towns has their own Board of Health, which makes Massachusetts exceedingly unique in that we have one of the most decentralized systems and have more local health jurisdictions than any other state. In fact, more than the states of California and Texas combined. This unique structure comes with substantial capacity, equity, and efficiency issues. Local public health and our state public health system must work closely together for our Commonwealth to have a comprehensive public health system to serve our residents. I know that you cannot read what's on the screen, but I can assure you that this is an incomplete list of responsibilities, and the list gets expanded every single year. As a state, we ask a lot of our local public health system. In fact, a quick search on the legislature's website last week returned 38 pending bills that will require new actions or responsibilities for our local boards of health. Despite the challenges, our local public health colleagues carry on the hard work every single day. We witnessed firsthand how these challenges were exacerbated during the COVID pandemic. We know that we need a better system. A system that guarantees that no matter what your zip code is, you are going to have access to quality local public health services that meet established standards. A system for healthier Massachusetts. We are committed to creating that system. We are on a journey to improve the health of every person in the Commonwealth, and it starts with us. In 2016, the Special Commission on Local and Regional Public Health was established by the Legislature to assess the effectiveness and efficiency of the municipal and regional public health systems, and to make recommendations regarding how to strengthen the delivery of public health services and preventive measures. I was working in local public health system at that time and had the distinct privilege to serve on the Special Commission with Rep. King. After many in-person meetings, we don't have Zoom at that time, over 2 years, the Special Commission released the Blueprint for Public Health Excellence report in 2019, with 6 interlocking recommendations to transform our local public health systems. In many ways, the Blueprint report is like a roadmap for this journey. Just when the COVID pandemic started during the spring of 2020, the SAFE Act was enacted, and it established a new section in the Mass General Law, Chapter 111, Section 27D, and included some of the Special Commission's recommendations, such as promoting cross-jurisdictional sharing of services to improve the efficiency of delivering public health services. The SAFE Act, which we now call SAFE 1.0, also directed DPH to establish a set of minimum standards for local public health, which we did in the fall of 2023. The pandemic highlighted many capacity shortcomings within our local public health system. We are very grateful for that the Legislature in 2021 designated one-time funding to the local public health systems. This funding has been the primary funding source for much of our work to implement the SAFE legislations. This funding, which expired in fiscal year 2027, allows us to build the foundation of a better local public health system. With lessons learned from the COVID pandemic, as well as experience we have together with our local public health partners on implementing SAFE 1.0, We know that we need to further our local public health system transformation work as envisioned by the Special Commission. We are very grateful that the legislature passed SAFE 2.0 late last year. By working together with sufficient funding to implement SAFE 2.0, we can create an equitable local public health system in Massachusetts through cross-jurisdictional service sharing, a unified data solution, a highly skilled and trained workforce, and a set of performance standards. These efforts will significantly improve the lives of every person who lives and works in Massachusetts, bringing hope for a safer and healthier Commonwealth. So what is SAFE 2.0? It institutionalized much of the ongoing system transformation work. It codifies recommendations by the Special Commission, the Blueprint Report. It raises visibility and highlights the importance of local public health services. It establishes mechanisms for funding local public health while maximizing efficiency. It also sets accountability by requiring all local boards of health to meet established performance standards. Let's take a look at 4 key SAFE 2.0 requirements and how we are implementing them. As a side note, these 4 areas of SAFE 2.0 aligns with 4 of the 6 recommendations from the Blueprint Report by the Special Commission. For cross-jurisdictional sharing of public health services, our Public Health Excellence or PHE grant program now supporting 92% of our municipalities, covering 322 municipalities across the Commonwealth, and supporting more than 300 municipal positions. We established the Massachusetts' first ever performance standards for local public health in the fall of 2023, which we are calling Phase 1. We are well underway to move to Phase 2, which is the national framework called Foundational Public Health Services, as envisioned by the Blueprint Report. In workforce training, we established the first and only multi-tiered local public health training infrastructure in Massachusetts. One example of our training infrastructure is the nurse consultant program run in partnership with UMass Amherst, where regional nurse consultants provide technical assistance to local public health nurses. There is a simulation training space being developed at UMass Amherst for nurses. And we are developing a first in the nation comprehensive data solution for local public health we call Metric. As part of our planning work towards setting the National Foundational Public Health Services framework as our next phase of performance standards, we conducted an extensive review of local public health staff's capacity and expertise towards this national framework. This slide is an example of our findings. Light-colored bars are the capacity to provide services, and the darker colored bars are on expertise or knowledge. The longer the bar is, the better the capacity or expertise. If you look at the left side of the slide, which is on municipal funded staff, there is a consistent lack of capacity in all of these topics, even though expertise in these areas are generally better. The right side of the slide is on PG shared service grant funded staff. Our findings show that shared service grant funded staff are bringing both capacity and expertise to the municipal-based public health system. In addition to ongoing work, SAFE 2.0 also brings new requirements. Equity is now written into law in all aspects of the work. There are several new reporting requirements for both BPH and local public health. SAFE 2.0 also revised the Special Commission. Now, let's take a look at how we're funding our local public health as a state and our current state investments in transforming the system. Let's look at the top left figure first. For last fiscal year 25, we spent approximately $234 million as a state in providing local public health services. And the three primary funding sources are local, which are municipal funds, the state appropriation from the GAA, the state budget, and federal grants received by BPH and distributed to local public health. Note that most of the existing federal grants for this purpose expires at the end of FY27. For the figure at the top right corner of the slide, we are showing the existing uneven FY25 local investments in funding public health services in 4 Massachusetts communities, all of them having a population around 30,000 people. It ranges from $1.34 million in town A to only $244,000 in town D. This implies that depending on where you live, a resident can expect to receive different levels of public health protection. This is also a result of a system that relies so heavily on local municipal funding, as you can see in the bottom left figure. Nationally, on average, state-level funding sources contributed to about 1/3 of per capita funding for local public health services. And lastly, the bottom right figure shows the average local public health funding by source. Compared to the rest of the country, we fund local public health differently. As I mentioned earlier, when you rely so heavily on local funding, the variability of how each city and town fund their respective local public health departments has created substantial inequity in the provision of public health services, as seen in the top right figure. And now I would like to invite a few of our local public health colleagues to offer some example of how we are maximizing the investment, such as the PHE grant funding on system transformation. First up, I would like to invite Meredith O'Leary. Meredith is the Northampton's Public Health Commissioner. Northampton leads the Hampshire Public Health Shared Services Collaborative. Meredith?
Thank you, honorable members of the legislature, Commissioner Goldstein, Director Wong, colleagues. Thank you very much for inviting me here today. Outdoor voice. Thank you, Senator Comerford. My name is Meredith O'Leary. I serve as the Commissioner of the Northampton Department of Health and Human Services. I've worked in local public health for more than 20 years across 3 of the 4 Western Mass communities, serving in some of the larger cities within the regions. That experience has given me a deep understanding of both the strengths and the challenges of local public health, particularly how fractured and inequitable it was before the foundation laid by SAFE 1.0 and now strengthened by 2.0. As we know, the structure of public health in Massachusetts has long posed significant challenges. For decades, small rural towns, especially in Western Massachusetts, in our region have operated with boards of health that were either volunteer-based or provided a small stipend for services. Yet these boards were expected to carry out the work of full-time professionals. Infectious disease, foodborne illnesses, environmental hazards do not respect the municipal borders. Yet the capacity to respond was often uneven and in many cases inadequate. That's where SAFE 2.0 has made a real difference. In Hampshire County, the Hampshire Public Health Shared Service Collaborative, run out of Northampton, now connects 14 communities through a shared service model. This means that all residents, no matter the size, the budget in their town, have access to consistent, high-quality public health protections. In Northampton, the Department of Health and Human Services consistently meets the state's performance standards for local public health. However, we do not stop at our city's borders. With strong support from my mayor and the DHHS leadership team, we've worked to make sure the stability and equity we maintain in Northampton extends into the surrounding Hampshire County towns that we serve, using our resources efficiently and fairly. Through this program, our staff are able to provide critical services to our partner towns. Things like restaurant, housing, and Title V inspections, vaccine clinics, infectious disease surveillance and investigation, as well as educational resources and community outreach. Smaller towns simply could not provide these services on their own. And it's not just the small towns that benefit. Larger communities gain too. Because our shared expertise extends to the underserved neighbors, this helps close long-standing health gaps in our communities. As Hadley's Board of Health Director, Ben Lipman, said, the HPHSSC is critical to protecting public health in Hadley. Their resources allow us to meet inspection and compliance standards we could not have achieved alone. Most importantly, HPHSSC has created the spirit of collaboration between Hadley and our neighboring towns, raising the bar for responsiveness and results. Before this collaborative, there were no formal structures for local boards of health to share services. Public health excellence has changed that by creating intermunicipal agreements that define roles, build trust, and allow towns to retain autonomy while benefiting from the shared services. Rather than replacing local boards, Northampton staff bolster their capacity, providing support exactly where it's needed. East Hampton provides a clear example of that impact. After their public health nurse retires, the town turned to the shared nursing team for support with infectious disease reporting, vaccine clinics, homebound vaccinations, and health education. As Director Ryan Griffin, the public health director there, said, the support of the HPHSSC has been essential in maintaining uninterrupted services for our residents while the position was vacant. Granby Board of Health member Ellen DePoint shared, before shared services, I was completely overwhelmed by what a Board of Health member was expected to do in a small town with no budget. We received only $700 a year to do the work of a full-time Board of Health member. I had taken a food management class and thought I was trained for inspections. But in practice, there was so much more to it than I realized. I am so thankful to have this support now, and I hope it never changes. And lastly, in Huntington, a rural community of fewer than 3,000 residents, located about a half an hour from the nearest hospital or pharmacy, public health excellence means access to monthly blood pressure clinics, MAVEN monitoring, trusted vaccine information in clinics, Narcan distribution, and a variety of health education programs. Local Board of Health member Kathleen Peterson emphasized just how vital these services are, particularly in geographically isolated communities like theirs. These are not abstract benefits in public health. We're about prevention, and these are life-saving services reaching residents who otherwise may have gone without. The COVID-19 pandemic made painfully clear how vulnerable small towns are when they were left on their own. Safe funding ensured that no community had to face emergencies or poor service deliveries in isolation. If funding is not sustained, we risk reversing all of this progress. Communities will face reduced services and loss of essential programs, higher costs as towns scramble to rebuild capacity, loss of expertise to manage complex cross-border health threats, failure to meet performance standards, widening disparities across our state. Southampton board member Caitlin Rooks warned, now that we have joined together to strengthen public health in our region, I fear the forward momentum we've gained will be lost through budget cuts and shifting priorities in Western Massachusetts is certainly better because a result of this program. Massachusetts has long been a leader in public health, and SAFE 2.0 is building on that legacy. It's created a model of collaboration and excellence that strengthens us as a state. At a time when public health across the nation faces chronic underfunding, erosion of trust, and growing division, this program has instead brought resilience, equity, and unity to 14 very different communities in Western Massachusetts. Now it's time to build on this success. Sustaining SAFE 2.0 funding will ensure that every resident, wherever they live in a city, a town, a rural hilltop, has access to the same essential public health protections they deserve. I thank you for your time and thank you everyone for your support.
Next up, I would like to invite Bill Murphy. Bill is the Director of Public Health for the City of Framingham. Bill is representing the MetroWest Shared Public Health Services. Thank you.
Honorable members of the Senate and House of Representatives, thank you for the opportunity to speak with you today. My name is Bill Murphy. I serve as the Director of Public Health for the City of Framingham and Vice President of the Massachusetts Large Cities Health Coalition. I also sit on the advisory board for the MetroWest Shared Public Health Services, a shared service arrangement funded by the Public Health Excellence Program that supports 9 municipalities. The majority of Framingham is located in an environmental justice area. Delivering equitable services is extremely challenging when we face issues such as migrant family support, homelessness, substance use, and housing and food insecurity. Effective public health service depends on people. When I arrived in 2023, 9 of our 16 staff positions were vacant, including a public health nurse and 3 inspectors. Without qualified staff, we cannot meet state mandates, maintain compliance, or address inequities. Public health excellence grant funding has been critical to addressing these challenges. It has allowed our new staff to attend trainings and conferences that our local budgets don't support, ensuring that our team is skilled, credentialed, and current in a rapidly changing public health landscape. Most importantly, the funding has helped us fill our vacancies and properly train new hires while strengthening workforces and infrastructure across our shared service communities. The results speak for themselves. When I arrived to the city, 22% of our school population did not have their basic required vaccines. In partnership with our schools, Public Health Department launched local clinics, helping overcome language and access barriers, and the deficiency rate is now as low as 3% in our most vulnerable schools. Field service staff continues to help close this gap by supporting weekly vaccination efforts in the Framingham Public School, ensuring more children are protected and healthier. We also now have access to a regional epidemiologist, something Framingham could not support on its own. Recently, our epidemiologist analyzed 8 years of hepatitis C data and HIV data and presented findings to the local Board of Health and city officials. This local evidence demonstrated the impact of a regional syringe service program and gave decision makers the data needed to support harm reduction efforts. This is what evidence-based public health looks like. We are closing the gaps in maternal and child health with the PHE funding. MetroWest municipalities partnered to launch free birthing classes, postpartum support groups, and community baby showers. These programs offered in English, Spanish, and Portuguese were offered in those languages. For example, a recent Portuguese language birthing class at the Framingham Library served 10 expected mothers. Not only would these they would not only receive instructions from a certified doulist, but also gain access to vital public health resources such as vaccination schedules and wellness information. There was an opportunity also to dispel myths and concerns about vaccines and medicines. Public health is not only meeting mandated challenges, but emerging challenges as well, and we're meeting them head on. In the past 6 months, we have had to issue multilingual alerts about PFAS and local fish and harmful algae blooms in recreational waters. We have supported new refugees arriving in the communities, investigated new diseases, and collaborated on cannabis farming. Having shared services has given us the stability to address these emerging public health issues while still carrying out our core responsibilities. The investment in local public health since COVID has been significant, and it has been transforming how we serve our residents. Guided by the Special Commissioner on Local and Regional Health and the Blueprint for Public Health Excellence, we are building stronger regional partnerships, professionalizing the workforce, and using data to inform our work. These efforts are laying the foundation for a modern and equitable public health system in Massachusetts. But to sustain this progress, continued investment is essential. The Public Health Excellence Program makes it possible for every community large or small, urban or rural, to access professional staff, regional expertise, and evidence-based services. I urge you to protect and expand this funding so we can continue to deliver on promising of a strong, modern, equitable public health system for all of Massachusetts residents. Thank you very much.
Thank you, Bill. Next up, I would like to invite Derek Neal. Derek is the Chief Public Health Officer for the City of Cambridge and represents the Public Health Collaborative between Cambridge and Somerville. Derek? Good afternoon, everyone. It's an honor to be here. And I'll dispense with the elephant in the room. You'll hear a twang in my voice, and that's because I'm the son of the South. Between Florida, and I spent prior to coming here 4 years ago, I spent 10 years in Texas running various health departments. So if I'm not clear on something, please feel free to approach me after this meeting. So it's an honor to be here and sincerely appreciate that. My name is Derek Neal. I'm the Chief Public Health Officer, the Cambridge Public Health Department, and we are part of the Cambridge Health Alliance, but we are located within the city of Cambridge, and our operations are confined within that city outside of the shared services, which I'll speak about. The Cambridge Public Health Department is one of only 3 nationally accredited local health departments in Massachusetts, a designation that was renewed this year for an additional 5-year period. I'm very proud of the department's accomplishments, but despite that accreditation and the excellent staff at the department, public health work at the local level is incredibly challenging. Our decentralized system here in Massachusetts makes it even more so. Issues impacting public health do not recognize municipal boundaries, especially in densely populated areas such as Cambridge and Somerville. Our Public Health Excellent Grant with neighboring Somerville is greatly enhancing our collective capacity to undertake more creative approaches to our work and deliver services more efficiently and effectively. The Somerville-Cambridge Shared Services Agreement is employing 3 main strategies for building a stronger, more equitable public health system. We have focused on modernizing our data and operational systems, strategic hiring, and innovative public health research. I'd like to share a few examples to bring alive the upgrades to our work being supported by the Public Health Excellence Funds. The grant has allowed us to enhance technical capacity for inspections in Somerville and Cambridge. The 2 cities work with an inspectional software vendor to fix system gaps, preventing data loss in food inspection reports. Somerville and Cambridge inspectors now meet monthly for roundtable trainings with subject matter experts to help them navigate complex housing cases, allowing them to better serve our residents. These trainings include such varied topics as asbestos, identification, pool inspections, and unique situations where inspectional services authority is not clear. Last week, for example, inspectors discussed a case in which complainants were staying at a hotel. Complainants were staying at a hotel. These individuals reported some medical symptoms and went to the hospital. Later, after tearing wallpaper from the walls in 2 rooms, they discovered mold and mildew. As the complaints were not permanent occupants of the room, the inspectional team wasn't sure how much authority they had in following up. These complainants have been requesting significant documentation from inspectional services, considerably more than ISD would be able to require the hotel to provide. Our public health office was requesting additional information. The consultant helped ISD come up with a detailed plan on how to address the complaint, including what steps to take, what was permissible to ask the various parties to do, whether to address
just the two rooms that the complainant had stayed or include the other rooms on the floor, or how to respond to the various stakeholders in this case. On the staffing front, we successfully hired a regional clinical community health worker to serve both cities with a focus on engaging with vulnerable populations. The new CHW, our community health worker, is bilingual in English and Portuguese, enhancing the clinical team linguistic and cultural capacity. Her work helps engender trust among residents who do not speak English and enables her to serve as a resource beyond the role's main focus of outreach and TB care. With a Portuguese-speaking client who had complex medical needs, the focus was initially on his health. But during one visit, he confided something different. He was worried about losing his home. Because he trusted the community health worker, he felt comfortable sharing his fear. The community health worker listened and quickly connected him with information on rental assistance and eviction protections, arming him with the resources he needed to navigate his housing situation. What started as a health visit turned into a lifeline, showing how trust can open doors to resources that support various aspects of a person's life. Stories like this highlight how community health workers build meaningful connections that help people navigate challenges, improving stability, and strengthening the health of the community. The Shared Services Grant also enabled us to launch a unique rodent fertility control study in both cities, piloting a new bait product to reduce the rat population without using traditional poisons. We recruited residents to help with the study, raising the profile of local public health and engaging the community in an innovative experiment about the issue that matters to residents. This initiative caught the interest of local news media, further evaluating the work of public health in Cambridge and Somerville. Our epidemiology team is currently working with the environmental health to evaluate the result of this project across the 5 study areas. Progress is shared with the Rodent Control Task Force, hosted monthly by Cambridge and including staff from Somerville and Boston, along with our Public Housing Authority, Public Works, and other agencies. This work has opened the door to intermunicipal cooperation and exchange. Somerville and Cambridge have sizable unhoused populations spanning the 2 communities. Public health excellent funds allow the purchase of culturally appropriate hygiene kit supplies that were distributed via outreach efforts at a warming center and to unhoused individuals. Wound care kits were provided to shelter unhoused residents. Cooling kits were also distributed to assist during hotspot days. These materials were intended to both prevent infection and heat-related illness among unhoused community members and to lay foundation for ongoing relationships with these vulnerable populations. As you are likely aware, both the integrity of public health and funding for our programs is under attack by the current federal administration. We sincerely appreciate the efforts of the Commonwealth to protect important advances in public health and the advances that we have made in bettering our lives and communities. I have no doubt that the Public Health Excellent Grant across Massachusetts are improving the work of local public health, delivering results to residents, especially at a time when our funding is being threatened. Our community and partners are being weakened and the needs of our communities are growing. We look to you to protect local public health as an essential service. In the absence of our Public Health Excellence Grant, Cambridge and Somerville would soldier on because that's what we do in local public health. But the caliber of our work in some areas would not be the same. Our goal is continuous improvement in an attempt to provide the most effective and equitable services possible. This funding helps fuel our ability to innovate on behalf of the communities we serve. Thank you for an opportunity to share our experiences.
Thank you, Derek. I would like to invite Victoria Seltzer. She's the regional epidemiologist of the Montachusett Public Health Network, led by City of Fitchburg. Sorry.
Good afternoon, everyone. Thank you so much for being here. My name is Victoria Seltzer, and I'm the epidemiologist for the Montachusett Public Health Network. Led by the City of Fitchburg, the MPHN is a collaborative of 13 cities and towns that serves approximately 180,000 people in northern Worcester County. Thank you to Commissioner Goldstein and to the Office of Local and Regional Health for the opportunity to speak today. I'm proud to live and work in a state that recognizes the consequences of fragmented and underfunded local health departments and responded by investing in a more equitable public health infrastructure. Under the prior local public health model, most Massachusetts health departments lacked adequate funding, staffing, and expertise. As a result, local public health struggled to meet a growing list of statutory requirements and national public health standards. The Public Health Excellence Program has increased the individual and collective capacity of communities to provide these essential public health services across the Commonwealth. Through regionalization efforts, MPHN has been able to deliver services more effectively while remaining flexible, responsive, and innovative in meeting the evolving needs of our residents. Local public health is uniquely positioned to serve as a critical access point for vaccines, particularly for vulnerable populations such as uninsured children and homebound seniors. Despite this, MPHN communities previously had limited to no ability to offer immunization services. With the support of the PHE program, MPHN has taken significant steps over the past year to respond to these longstanding gaps. This work reflects a growing alignment with the newly established performance standards and represents a meaningful step toward improving vaccine access and uptake in our communities. As part of our commitment to establishing robust immunization services, we work to enroll as a Vaccines for Children provider. This allows us to receive all vaccines on the pediatric schedule at no cost. Through twice monthly clinics implemented entirely by shared staff, MPHN has administered over 1,000 doses of routine pediatric vaccines, such as the MMR and polio vaccines in the past year. Without access to the resources PHE provides, these services would not be available to most MPHN residents due to the associated administrative and financial burdens. As a result of our clinics and our partnerships with our school districts, there have been significant improvements in compliance with school immunization requirements, particularly in our two biggest communities of Fitchburg and Leominster. Between the end of the 2023-2024 school year and the end of the 2024-2025 school year, the number of students non-compliant with school vaccine requirements in 3 of our public schools decreased by between 50 and 70%. I want to share the perspective of school nurse leader at the Fitchburg Public Schools, Jackie Lassard, who spoke to the impact of our joint efforts. She says, the partnership between the Fitchburg Public Schools and the Fitchburg Health Department has been instrumental in providing equity and access to care for our students. By expanding immunization services, vulnerable populations who might otherwise face barriers to healthcare are now better supported. These efforts have not only improved compliance with state requirements, but have also reduced absenteeism, increased family trust, and ensured that every child, regardless of background, has the opportunity to thrive in school. Jackie's reflection reminds us of the meaningful impact that well-resourced public health programs can have. As we consider these successes, we must also acknowledge the challenges that lie ahead. Decades of progress in public health are being threatened by an unprecedented shift in federal priorities. It will be up to Massachusetts to preserve access to the evidence-based public health practices that protect and promote the health of all residents. Continued investment in local public health through the Public Health Excellence Program will be essential to meeting future challenges. Thank you all for your commitment to advancing public health across the Commonwealth and for your dedication to creating healthier, more equitable communities. Thanks, everyone.
Thank you, Victoria. This is just to remind everyone how essential and critical our local public health system is. Again, this is an incomplete list. Thank you for the opportunity to share the information today. Turning it back to you, Commissioner.
Thank you, Sam, and thank you to all of our presenters who I think did a fantastic job of describing the breadth and depth. The depth of local public health and services. That is the end of our prepared remarks, but we are happy to answer any questions that anyone may have. Looking to our hosts.
Caitlin from my team may have questions from online, which we can integrate if you're okay with that.
Yes, please.
Maybe I can ask you. So according to the graph, 34 million, it looks like, from the federal support, 9 million from the state. So what will we do looking forward? How much of that do you think we're gonna have to backfill?
Well, I think and Sam should jump in because he knows the numbers much better than I do. But almost all of that federal investment will be gone by the end of fiscal year 27. It was all one-time investment either through ARPA funds that came to the state and then got placed down at the Department of Public Health, or funds through what's called the Public Health Infrastructure Grant that was funded to CDC and CDC put out to local public health. We'll see what happens tonight, but absent a budget at the federal level, I'm not sure we can count on the Public Health Infrastructure Grant beyond this fiscal year. So I think we have to recognize that those funds will go away at the end of fiscal year 27. We have some time until then, right? We have about a year and 3 quarters until the end of fiscal year 27. But we should be thinking as we go into fiscal year 27, what else is there that we could incrementally build to get us to the right place for local public health? And I'll just call out that we are doing our best to spend those dollars over an appropriate amount of time to guarantee investment to local public health so that people can hire and maintain those hires. But we are looking at the end of fiscal year 27, sort of January 2027 to June 30th, 2027, that we will likely be about $6 million short in our commitment to local public health. And so as we go into the next fiscal year and into the budget cycle, I think it's important to keep that in mind. If we want to maintain these services and we want to make sure that local public health can hire appropriately, can train appropriately, can maintain their staff, we're going to have to start to increase the amount that the state is investing in local public health.
And just to follow, so are there any thoughts on, obviously this was an improvement from prior, and there's been some obvious benefits that have been documented. Are there other sources that we can leverage from communities outside of state direct funding, given that there's going to be many, many challenges on state funding going forward?
I think we're certainly looking at those possibilities, and I think Sam's running a pretty robust process to identify other sources of funding. But we should recognize what else is on that slide, which is that we disproportionately fund local public health through municipalities in the state compared to other states.
That non-government,
But I think the same idea that Sam was bringing in, that there are very wealthy communities that are going to have more community supports that potentially step in. And there are less wealthy communities. And what we're really striving for is an equitable system so that all communities have the same local public health resources. And if we shift to community-based organizations, we are likely to see those disparities grow. Was there a question online?
There are no questions online at this point.
Other questions from the audience?
I have a question.
Yeah.
I wonder if you could just talk a little bit more about the standards that DPH and local and regional public health are embracing, because I actually think that's very exciting. And Director, you talked about, getting to the framework, the national framework. If you could just explain that a little bit more, because it was envisioned in SAFE too, that we would start with standards and then with capacity building, we would get to be able to reach those standards. And I think it's a wonderful advance.
Yeah, he's getting ready to go. This is Sam's sweet spot, so I'm gonna let him take this one.
Okay, thank you.
Thank you, Commissioner. Thank you, Senator. That's a great question. If you remember in my presentation back in the fall of 2023, we established the first ever performance standards at that time. That's what we call phase one, which is basically existing statutory and state regulatory requirements. That's the foundation. We even though phase two is called foundation, but this is really the basic of the basic. We want to make sure that everybody can achieve the basic first. We're not there yet. We're not there yet. While we are helping everybody through the PEG grant program, building the capacity to reach the basic phase one, we are already investing our resources to look at what would phase two look like for Massachusetts. We are developing work with our local public health partners to visualize what would that future state look like. And there's tons of planning work underway right now to get to that. You're welcome. Michelle.
Director Wong, I wanted to say that in those standards, I know there's a lot of investment as well on workforce equity and attracting new folks to public health and this field. Could you speak a little bit about the success or challenges around that equitable workforce development?
In full transparency, I did not plan that question. I forgot to mention that even for phase one performance standard, even though those are existing statutory requirements for local boards of health, we also included the workforce standard from the blueprint as part of that. That lays the basic requirement for our workforce, the credentials, the educational requirements. To support local public health workforce to reach that workforce standard, we are also investing in training programs, but also in recruitment program as well. As a matter of fact, we have a existing program looking at working with a couple of community colleges to provide more or less like a internship on steroids, if you will. It's not as robust as a co-op, but it's like a co-op-like type of program, while the students is getting education. At the same time, that student is also working part-time at a local health department with our support. So gaining the knowledge, going through the training, getting the credential while going to school. The goal is at the end of the education program, that students is fully trained, has experience, and can go to work right away. That program just got started recently, and we're working with 2 community colleges on that.
Expansion of state benchmark.
We are counting on, this is more like a pilot to see how it goes. If it goes well, we'll be asking for more funding to expand that.
If there aren't any other questions, I know we'll hang around a little bit to answer any questions. I want to just take one more moment to thank Representative Kane and Senator Comerford for pulling this together. Thank you. We're looking at a lot of great people who've done a lot of great work. Thank you all for your support.